morning, everyone, and welcome to our online forum. I'm Dr. Bizos, and this morning I'll be talking on Ankyloglossia, a congenital condition in which the lingual frenulum is too short, causing a restricted tongue movement. I would like to acknowledge Professor Pierre for advising me and helping me with this talk, as well as welcoming Dr. Maina, our previous fellow from our previous pediatric ENT fellow who will be joining us, and Tanith, one of our speech therapists, who will also be joining us on this talk this morning. These are my disclosures. So baby T is a 15-week-old male born at term with a normal birth history and immunizations up to date. However, growing along his own curve at the -2 line. And this baby presented with a history of inability to latch well and adequately breastfeed. Clinically, the child had no signs of dysmorphism. He had a normal oral cavity with no clefts present, but the tongue tie was clinically present, affecting the child's suck, and on palpation of the tongue tie, one could appreciate mucosal fibrous bands. You can appreciate this thick fibrous band below the tongue of the lingual frenulum. So background of anatomy, the tongue is attached to the floor of the mouth via the lingual frenulum. It's a dynamic layered structure formed by oral mucosa and an underlying floor of mouth fascia. It's mobilized into a midline fold with tongue elevation and retraction. The base of the frenulum consists of a V-shaped hump of tissue in the floor of the mouth, which houses the two Wharton's ducts on either side, and the sublingual salivary glands empty through tiny ducts on either side of Wharton's ducts. There are superficial veins running through the base of the frenulum, which are known as Raynaud veins. Operative interventions were proposed already in Greek medicine in the Middle Ages, and competition arose between midwives who used their nails to detach the frenulum and surgeons who were allowed to use instruments. During the last century, the justification for frenotomy has shifted from improved language to enhanced feeding, and despite the high frequency of the intervention, little research has been performed on its benefit, which remains a controversial topic among different groups of health professionals. There are various instruments used that have been dated back to 1666 in order to aid a tongue tie release. On Finger 4 is what we currently use at Red Cross, which is a grooved retractor manufactured from a teaspoon, enabled to assist adequate exposure during surgery. So with a nationwide effort to increase breastfeeding rates in newborns and infants in recent years, there has been a dramatic increase in the diagnosis of tongue tie and the resultant referral to an otolaryngologist. So when should we refer to an ENT? So babies with poor latching or poor feeding, and older children who have a speech impediment, which affects their pronunciation. However, they should be reviewed by a speech and language therapist first. Speech delay and aspiration or dysphagia are not related to tongue tie and shouldn't be believed to be the cause of or secondary due to a tongue tie, but an ENT surgeon should investigate further for these symptoms. The speech and language therapy review includes a holistic assessment which considers cosmetic as well as oral hygiene, feeding, range of movement of the tongue, as well as the speech and psychosocial benefits of going through it. And the management of a speech therapist explores both managing the parental expectations. With management, understanding a parent's expectations of surgery is essential, and appropriate counseling should occur. For example, surgically releasing a tongue tie will not immediately and automatically resolve any speech errors or breastfeeding difficulties that are co-occurring, and the child will need speech therapy post-surgery to work on the sounds despite the release of the tongue tie. This may also be due to the child's reduced awareness of oral space and tongue range of motion post-surgery. There is no maximum age of being able to undergo surgery, nor are there consequences of waiting till an older age. And if surgery is decided, the course of management, speech therapy will commence 7 to 10 days post-surgery to allow for adequate healing post-operatively. May then start lingual range of movement, including tongue protrusion, circumambulation, elevation, and retraction exercises. The classification of tongue tie by Corylus permits identification of tongue tie ranging from type 1 to type 4, where type 3 and type 4 frenula can sometimes go unnoticed with macroscopic examination and can only be appreciated with palpation. On type 3 tongue tie, there's a 50% of the tongue is tethered, and the tongue can appear normal, but the mobility of the tongue is limited. This as well in type 4 tongue tie, where there's limited mobility of the tongue due to a fibrous posterior band and limitation of the most distal portion of the lingual frenulum. So is it significant anatomically? When looking at this, there are several studies that have showed various guidelines based on the following criteria to classify tongue tie. So one should look at the length of the frenulum, upward tongue mobility, as well as if there's limited tongue protrusion, impaired lateral mobility of the tongue, and if there's a thick fibrous band cord palpated on physical examination. And when should we intervene is still a topic of debate. In a Cochrane review, it was documented that frenulectomy aided in reducing a mother's nipple pain and had positive short-term effects on breastfeeding. But it has been cited as a poor cause, and as well as tongue tie being cited as a poor cause of breastfeeding and maternal nipple pain. However, it's important to educate patients on the multifactorial nature of breastfeeding and to set these realistic expectations prior to recommending the procedure. When do we intervene? So babies who present with difficulty feeding, poor lacting breastfeeding, and poor weight gain are definitive indications in which we should breastfeed, as well as having difficulty swallowing with a decreased mobility of the tongue, and if there are pronunciation difficulties, but of note, not speech delay. It's more to do with the pronunciation of a child's speech. So frenulectomy refers to an incision in the frenulum that frees the tongue from the floor of the mouth, and it's appropriate in patients with symptomatic type 2 to type 4 tongue tie, provided that the frenulum is not fibrotic. Usually we perform these procedures in children less than a year when a mucous membrane is clinically palpable, and in neonates and infants it may be performed under local anesthesia in an outpatient setting. A frenulectomy refers to a complete excision of the lingual frenulum. It's a more invasive procedure and may be difficult to perform on smaller children. However, the results are more predictable and the occurrence rate of tongue tie is lower. So this is the example of positioning of a child intraoperatively for frenulectomy. Intermittent multiple nasal intubation is preferable for adequate access, and oral intubation may also be performed with the child, where the child is then placed flat with the head and the mouth open. A grooved retractor is used to retract the tongue, which you can appreciate in these images. A straight crowel hemostat is used to crimp the frenulum prior to release. Sterile curved scissors are then used to release the lingual frenulum as it's attached. And the incision should be close to the ventral surface of the tongue to avoid injury to the ductal orifices. And this is also to ensure adequate release of the frenulum. You can use your finger to gently massage the tongue at the deep end of the cut frenulum. The genioglossus muscle is the posterior limit of the frenulum incision, and one should compress the floor of the mouth with gauze to provide adequate hemostasis. In revision cases or in older children, interruptible absorbable sutures can be placed to prevent the release from adhesing back down onto the floor of the mouth. And it's always important to note that one should take care near the papilla of the submandibular ducts. On the other hand, a Z frenuloplasty can also be performed, and the surgical steps are basically starting by placing a silk stitch through the tongue tip to retract the tongue and hold it in place, apply an adequate lignocaine with an adrenaline, and one can draw the Z-plasty incisions, which can be appreciated in these images. You should start by making a vertical longitudinal incision along the length of the frenulum, and then 2 further incisions at 90 degrees, the first vertical one. 2 rectangular flaps that can then be created and elevated, and one can then transpose the 2 flaps adjacent to each other to close in the form of a Z-plasty with sutures of interrupted 5 ovicle. Complications of a Z-plasty specifically can be ranular formation, and then in general scarring, bleeding, as well as post-operative infection can occur. Damage to the tongue or salivary gland is a complication of releasing a tongue tie, and reattachment of the frenulum can occur. However, this is rare. This is a study looking at the major complications of tongue tie release, and the conclusions basically conclude that reporting of complications after frenotomy is lacking, and practitioners across different specialities should be monitoring and studying this in a more rigorous manner to better guide patients and families of the risks to benefits of this procedure. These are my references. Thank you.
Thank you, Agata. That was a very nice presentation. Are there any questions?
Can I ask Martin Douglas Jones, who's the maxillofacial surgery. Martin, do you have a comment from your perspective? You might have a slightly different perspective. Have you unmuted him? Yeah. Yeah, okay. You want to ask Tanit, would you like to comment?
Tanit is our speech therapist at British Care Hospital. Tanit, any comments, please?
Thank you, Agata, for the talk. I think you summarized speech therapy's involvement very nicely. Our main points to highlight would just be, the assessment, as you mentioned, for it to be holistic. You want to consider all the cosmetic kind of aspects. Can the child maintain oral hygiene and dental health? That's one of the important factors we look at. You covered breastfeeding well. Psychosocial, is the kiddie aware? You've got to consider, as they get older, the role that tongue movement would play in their romantic contexts as well, and then joining this with the parents' expectations of intervention. Management you covered very nicely and summarized well, so thank you for that. I just want to highlight that there are also risks, as you mentioned. So that the therapy intervention occurring within 7 to 10 days. That's very important, and to talk to the child about limiting their range of motion until this time period is very important, because we don't want to cause any scar tissue and possibly further any range of motion limitations from starting therapy too early. So yeah, our closing point is just, yeah, no upper age limit, and just that intervention is kind of unclear and controversial, as you mentioned, and we need more research. Thank you.
Thanks, Janet.
Thank you.
When I ask Shadia, so Shadia, do you have a stepwise approach? I mean, would you start just with frenulectomy, and then if it recurs, then do something more, or how do you approach it?
Sorry, Prof. Unfortunately, Professor Peer couldn't join in on this morning. But from what my understanding is if the child is young with a mucous fibrous band, then you would proceed to do a frenulectomy. However, if the child is older and if there's a thick fibrous band, then a frenulectomy is the preferred option in these kinds of children.
Okay, well, thanks for that. Yeah. Any other comments from anyone? Asher, have you got much experience with this? No comment. Okay.
All right, thank you so much, Aggie, for the nice presentation. We'll end the presentation and we'll meet on Friday morning. Thank you.
Thank you.